Hello, everybody. My name is Professor Derek Willis. As you've worked out, I'm in the UK and I'm an hour behind you. And it's a real pleasure to come and present to you on something that is very much an emerging field, which is palliative care for patients with Duchenne muscular dystrophy who are adults. And I very much have to say thank you very much to Professor Tracy Willis, who is a neuromuscular specialist in the UK, who we've been doing this journey together, and the RJH Hospital, and also the North Star Research Group, who have been helping us put together some of what I'm going to present today. So we did start looking at neuromuscular diseases as total, and this is really trying to pull out some of what we know about Duchenne muscular dystrophy. So I'm a palliative care consultant. I don't deal with children at all. I'm completely an adult palliative care physician, and I work in Shropshire in the UK, which is famous really for where Charles Darwin came from. I work in partnership with the local neuromuscular centre. I see both neuromuscular patients actually at the neuromuscular centre and at my local hospice. And as I say, the North Star is the national guidelines for patients with Duchenne muscular dystrophy, and I was involved in writing the palliative care guidelines for adults with Duchenne muscular dystrophy. So, why am I here talking to you about Duchenne muscular dystrophy? Well, it feels obvious, but it kind of makes sense to describe to you why we're now talking about this, in the fact that Duchenne muscular dystrophy is a changing disease. That it's my understanding that the average life expectancy is 28 years. I know that the various papers that will kind of put this higher, but the last review article that I could find was basically saying 28 years. So these patients are now living into adulthood, which is great news and down to an awful lot of committed and great work from a lot of people. The UK has a tradition of palliative care, and I know that some of that's not replicated across Europe. But children's hospices have very much been involved in the care of young people with Duchenne muscular dystrophy. We've done a research project which has looked at how that's changed, and now 66% of children's hospices are no longer taking patients with Duchenne muscular dystrophy because it's no longer a palliative diagnosis within childhood. So therefore, we are now looking at what is effectively an adult palliative disease. So one of the things that's a problem with talking about palliative care is that it means different things to different people, and defining that is hard. So when I often say palliative care to people, and when I say hospice to people, a lot of the time people think that what we're talking about is people who are dying, that it's end of life, and that very much all we're going to talk to patients and about when they're reaching the end of their life. For a lot of palliative care physicians within the UK now and Europe-wide, end of life is when we're talking about someone has a prognosis of generally about a year or two, not as people would generally perceive as being the last couple of days. But that's not to say that palliative care is exclusively concerned with those people who are reaching the end of their life. Palliative care is involved in symptom control for people where the focus of disease is no longer at curative or disease modifying. So symptom control can come and precede that point where we reach end of life care. And also, palliative care can be known as supportive care, which is working alongside when disease-modifying medications, being drugs, being used, particularly when there are patients that have symptom control issues, where again the disease trajectory is different. So there are three sections. There's supportive care, where active treatment is still happening. Symptom control, palliative care, where actually the disease-modifying drugs are being used, but the patients are not necessarily end of life. And end of life care, where we're looking at a patient being in the last year of life. Hopefully that has reassured you that when a palliative care physician comes along, all we're not going to be doing is exclusively talking about end of life and death. So obviously that is sort of part of my job. But some of what we're needed to look at now is about symptom control for patients with DMD. So what did we do as a research group? We decided that we should start trying to understand what an adult palliative care physician should be involved with patients with neuromuscular diseases more broadly, and specifically Duchenne muscular dystrophy. So we set up a clinic. We looked at those patients that felt like they belonged with that clinic where symptom control and end of life had become part of the issue. We then looked back and said, what do we do about advanced care plans? So advanced care plans are when you are planning ahead for what your future care should look like, and a little bit about symptom control and where next. So this really was in partnership between the local hospice here in Shropshire and the local neuromuscular centre, which is where a lot of this work first originated from and has been rolled out to some centres in the UK. And a kind of a shameless plug, we're hoping to roll this out more Europe-wide because we actually think that this is going to be helpful for all patients. So what did we first think about? So hub and spoke. If you look at the bicycle wheel, what you've got is a hub with the spokes reaching out to all centres. As you know, neuromuscular centres, because neuromuscular diseases are so rare, they generally would be looked at of a centre that covers lots of regions. So what we wanted to try and do was to provide palliative medicine advice in a large centre and reach out into those palliative medicine centres that were more localised to our patients. So a lot of hospices within our region will only have one patient with Duchenne muscular dystrophy, maybe two. So building an expertise is really difficult. We felt that building the expertise within the centre, the neuromuscular centre itself was more important, and then we would reach out to those people and support hospices locally. So hub and spoke. What did we then do? We tried to define at which point in a patient's disease process particular things should actually start being offered. So not forced, but offered to a patient. And very much within, as you'll know, within Duchenne muscular dystrophy, there are particular events that happen to certain systems. So respiratory system, cardiac, locomotor, GI, and we looked at acute hospital admissions. If someone is green, really as a palliative care doctor, unless there's some specific symptom control issue for supportive care, I don't need to be involved. When a patient on this what we call the traffic light system reaches amber, then patients do need to start thinking, and we need to be offering the chance to think about advanced care plans, about what future care should look like. So when someone's admitted to hospital, what some of the ceilings of care should be, where someone's future should be. And when a patient reaches the red within the traffic light system, that's when we start thinking about palliative care becoming involved. So if I take locomotor, unable to self-feed, dependent for all care will be one of the reds, that will be a flag to think, actually, maybe this person needs to be referred to our palliative care symptom control clinic. So we used this first of all to try and identify whether patients should be amber and should be having advanced care plans, or whether they should be red and whether they should actually be seeing me as the palliative care physician within a symptom control clinic and then offering ties to local services that patients had. So how did we get on? We looked at the entire kind of deaths within our service in 2023 to 2024. So of all the neuromuscular patients, there were 12 neuromuscular patients that 12 died in total, and 8 of those were known to the palliative care service. 2 refused referral in, and 2 were unexpected deaths. And of those patients, 5 were patients who had Duchenne muscular dystrophy. They were all offered, and one of those was refused referral. So it feels like from that, looking at our unit and looking back, the traffic light system for Duchenne muscular dystrophy seems to work. We're identifying at an appropriate level when that patient needs to be referred in for symptom control. So what we did then was that we took this traffic light model, we took the idea that a palliative care physician should be involved, and we've now made this part of the recommendation for every neuromuscular centre within the UK. So any neuromuscular centre should have access to a palliative care physician and should start accessing and using the traffic light system. What we've then done is we've now taken 3 or 4 centres who are looking at all of their patients with Duchenne muscular dystrophy, and they're going to apply the traffic light system to all of that caseload. And from that caseload, that will give us some idea of what the need is. Because one of the things that we're worried about hospices is that they feel that they might become overwhelmed. But if we've got some idea of how many of these patients there are out there who should be offered, not forced again, should be offered palliative care support, it gives us some idea when we're going to specialist palliative care about what we're actually talking about and the need we're actually generating. So, we've got a tool which is identifying people. It's working within a system. We've put that within the national guidelines, and we're trying to assess how much that looks like. So then what's next is how many and what does that burden look like for bringing it to other neuromuscular centres? And how do we actually roll that, both within the UK and within the Europe? And I'll be interested on people's thoughts for people who are actually online and looking here. So I guess one of the other questions that I haven't put there is we've identified when a patient is in that disease process. There's been some work on patients with FSHD and found that pain as a symptom is very common. What we need to start working out is for these patients with Duchenne muscular dystrophy, what does that pain cluster look like? We've very much done the accessing services, doing advanced care plans. The next part of our work is to work out how many patients specifically with Duchenne muscular dystrophy have pain. Pretty much 2/3 of the patients that I see in my clinic who have DMD have pain. And the type of pain that we're dealing with is obviously from not having as much muscle or kind of subcutaneous tissue within to be able to kind of cope with sitting in the wheelchair. So some of this is actually looking at the wheelchair, but actually generally we're not using opiates, and it's looking at neuropathic agents to help with nerve pain that we seem to be having more success with this. So, and also morphine and oxycodone, which are the drugs that we would tend to use within palliative care. As you know, lots of patients with Duchenne muscular dystrophy have real problems with constipation. So adding in medicines that increase that level of constipation is a bad idea. So there's a shift in the type of pain relief drugs that we're actually using. I'm aware I'm late, and that's entirely my fault. So I've bulldozed through that a little bit more, but I really wanted to leave some time for questions. Are there any questions that anybody actually has?